Hello everyone, today we'll be discussing renal stones, its clinical manifestations and investigations, and the surgical approach in case of renal stones. So without further ado, let's get started. First, coming into the renal stone, the most common manifestation, that is pain. The most common manifestation of renal stone is pain. Though it may be asymptomatic in case of small sized renal stone, it may be asymptomatic. Okay, so just by increasing the water intake, we can get rid of that. So no need of surgical management in case of asymptomatic stone or a stone size less than 5 millimeter, less than 5 to 6 millimeter. Do not. There is no need of surgical interventions. Coming into most common presentation, that is pain. This pain may be a fixed renal pain at the renal angle, that is a fixed renal pain at renal angle, and that is because of the impacted stone which is causing distal urinary flow obstruction, leading to the stretching of the renal capsule. The renal capsule is stretched, that is what is giving a fixed pain at the renal angle. But most commonly what we get is a colicky pain. Now depending on the location of the stone, it depends whether the pain will be localized to the renal angle or it will be a referred pain to other region. A stone which is impacted in the pelvic-ureteric junction or in the upper ureter is where the pain will be from loin transmitted to groin, and if it involves the obturator nerve in the upper ureter segment, it can lead to pain in the inner aspect of the thigh, and that is by obturator nerve. So the nerve involved here is the obturator nerve. Next, coming into a pain in the middle of the ureter. A pain due to stone impacted in the middle part of the ureter is because of iliohypogastric nerve, and a stone impacted in the lower segment of the ureter. That pain radiates along the ilioinguinal nerve. This is ilioinguinal nerve. Now very important one, that if a stone is impacted in the intramural portion of the ureter, intramural portion means the ureter, part of the ureter which is passing through the urinary bladder musculature is what is known as intramural portion of the ureter. Now if there is a stone impacted in that region, that can lead to strangury. Strangury means there is intense painful urge to pass urine, but on trying to do so, there will be few drops of blood that will come to the meatus. So there will be passage of few drops of blood on intense painful urge to pass or void urine. That is what is strangury. Remember, it is the most common cause of acquired cause of hydronephrosis. Most common acquired cause of hydronephrosis. So this is the pain which is the most common clinical feature that a renal stone presents with. There might be hematuria also, and there might be hematuria also. Now, if there is a pelvic-ureteric stone, and because of that the urine is accumulating here, and because of that there is capsular stretch. So what happens? So the stone at the pelvic-ureteric junction, which is blocking the urine from draining into the ureter, now the urine is blocking in the kidney, and that led to the distension of the renal capsule or kidney capsule. So what happens in this time, the patient will be presented with a fixed renal angle pain with a palpable swelling. So there will be fixed renal angle tenderness with palpable swelling because of that. But the stone will shift its position because of this distension. Now the stone is free and it will shift from its original position. It will come here from this side. So now what happens, whatever urine was accumulated, it will pass through the ureter, and this distension is now minimized, so there will be the swelling will subside as well as the pain will subside. That is what is known as Dietl's crisis. Okay, that happens when the stone is at the pelvic region of the kidney, and on distension of the renal parenchyma there is space, so the stone is actually, because of the gravity, it is pulled down, and the urine can now reach to the ureter. That is what is these are the manifestation of renal stone. What do you do? We actually do the investigation that we do here is USG, ultrasound, KUB. But remember, USG KUB is not sensitive for the lower part of the stones because there is bowel shadow in front of them, which can minimize the exposure. So the investigation of choice is always non-contrast CT scan of abdomen, or you can write NCCT KUB is what is investigation of choice. Now coming into how are we going to manage this condition. So please remember that management is actually depending on the symptoms. If the patient is asymptomatic, as I told you, or the stone size that you get is less than 5 to 6 millimeter, then we do not need to worry. So what we do is just observation is needed. Okay, but if there is symptom, if the patient is having symptom, okay, or the stone size is more than 5 to 6 millimeter, in that case what we have to go for, if the condition permits, if there is no contraindication for the next procedure, that is ESWL, extracorporeal shock wave lithotripsy, so we can perform this thing. Okay, so ESWL has to be performed. But if there is contraindication for that, we either have to go for PCNL, percutaneous percutaneous nephrolithotripsy, or we can go for RIRS, that is our retrograde intrarenal surgery. Okay, so either we have to go for percutaneous nephrolithotomy or RIRS. Okay, this is percutaneous nephrolithotomy, because we are reaching the parenchyma of the kidney by puncturing the skin and subcutaneous tissue. So it's a TOMY, and this is lithotripsy. This is lithotripsy. Understood? So we assess whether there is a symptom and stone size is more than 5 to 6 millimeter. Then we go for extracorporeal shockwave lithotripsy. That is the first line of management. This is the first line of management. If there is contraindication to that, or if this procedure fails, if there is contraindication or this procedure fails, then we go for percutaneous nephrolithotomy or RIRS. Understood? Now coming into each of them. So first coming into extracorporeal shock wave lithotripsy. So here what happens, see here, this is what is extracorporeal shock wave lithotripsy. This is extracorporeal shock wave lithotripsy. Now what is happening here, you can see there is a blast wave or shock wave that is provided. That is an ultrasonic wave. That is an ultrasonic wave that is provided, and this wave is targeted to the stones. This wave is targeted to the stone. Actually there was a big stone, there was a stone like this, okay, more than 5 millimeter, okay, and this stone was targeted by this ultrasonic blast wave. This is a dynamic wave that goes and it shatters the stones into small pieces. Now these pieces of the stone, they will go distally through the ureter. It will be excreted out with the urine. Okay, so that is what is extracorporeal shock wave lithotripsy. Blast wave is applied and the ultrasonic wave is targeted to the stones. Now the stone will be shattered into smaller pieces, and here the patient has to lie and has to be very much still. No movement is allowed. Okay, this apparatus where we actually perform ESWL, this is known as Dornier apparatus. Dornier apparatus. That's the strongest apparatus that is needed for providing this ESWL waves, that is the shock waves. Okay, so here the shock wave is coming and it is shattering this piece of stone into small pieces. Okay, now you can see, now see, this is the extracorporeal shockwave lithotripsy. This is extracorporeal shockwave lithotripsy. Here what happens, you can see there's a blast wave or the ultrasonic wave that is provided and targeted to the stone. Patient is lying still. Okay, the patient is lying still, and the shock waves are targeted to the stones. Now the stones will be fragmented, and these fragmented small pieces of the small piece of stones will come and they will reach the ureter, and gradually they will be released outside. So you can see that if the stone has got the infective foci inside it, if the stone has infective foci inside it, so when the shock wave is fragmenting the stones or shattering the stones, that infective foci will be released, and distally it can cause urinary tract infection. Obviously, because of the trauma, there will be pain, which is most common complaint the patient might be having hematuria. Okay, now you can also see that the patient, the fragmented or shattered stones are making a street which is made up of stone. The appearance is like a street which is made up of small fragments of stone. So that's why it is known as stone street. This is known as stone street or Steinstracy. Stone street or Steinstracy. Okay, that is what is needed to know. So complication, pain, hematuria, UTI, Steinstracy, these are what you have to be knowing. Now, a very important thing, that the apparatus which is used for delivering the shock wave, that is known as Dornier apparatus. It's a very strongest apparatus which will deliver this shock waves, this ultrasonic waves. Okay, and this is what is going to happen. Now this is not a single sitting surgery. You need multiple sittings that are required in case of large stone. Okay, you have to do it for multiple time, and if the patient is not compliant enough, who is not wanting a multiple sessions to be done, so in that case it should not be done. So what should we do then? As I told you, that if there is any contraindication or if ESWL fails, then we will go for percutaneous nephrolithotomy. So what are the contraindication of ESWL? What are the contraindications of ESWL? So there are some stone related contraindication, like if the stone size is more than 1.5 centimeter, yes, it is centimeter, more than 1.5 centimeter, the ESWL should not be done, because it will, as I told you, it needs multiple settings, or it needs more energy waves to blast the stone, and that may harm the patient. So stone size more than 1.5, or if it is a very hard stone, if it's a very hard stone like cystine stone or calcium oxalate stone, so we should not go for that. Okay, like cystine stone or calcium oxalate stone, then we should avoid this thing. Now patient related contraindication, obviously if she is pregnant, there is very much high chance of abortion in that patient, and also the baby can suffer from the shock waves. Next, if the patient is obese, that also needs high energy, and also that is contraindication. Please remember, it is also not done in case of children, because as I told you, the lying posture is needed. They cannot lie still. So I cannot do in children also. Another contraindication patients related is if there is any cardiac pacemaker is present, as its functioning can be interrupted by the shock waves, so we cannot perform ESWL if the patient is having this thing. Even if the patient is having any bleeding disorder, then it is better not to do that. Remember, as I told you, that this stone will come through the ureter. So suppose the patient has a primary stone here and also there is distal ureteric stricture, or there is also a secondary stone, or there is also a primary stone in the ureter distally. So I am not going to do this ESWL because ultimately this stone has to cross this ureter. If there is already a distal obstruction, I'm not going to do that. Okay. So if there is distal ureteric obstruction, and another is if there is lower calyx stone. Okay. If there is lower calyceal stone, that means that is not possible for the stones which are present in the lower calyx. Agar upper calyx mein hoga to it can easily pass, but if it is in the lower calyx, it is very much hard for the stone to cross the gravity. That is why this is also a contraindication. Okay, understanding this is ESWL. As I told you, if there is contraindication, or if the patient is not if the stone is not removed by ESWL, okay, then I have to go for PCNL, that is percutaneous nephrolithotomy. Percutaneous nephrolithotomy. So as the name suggests, there will be percutaneous, means I have to put a guide wire. Okay, I have to put a guide wire that is inserted next to the stone here. You can see this is the stone. So this guide wire is put next to the stone, and after that a nephroscope is inserted and the stone is now fragmented and removed. The stone is now fragmented and removed. You can see this. Okay, so even if there is distal obstruction, I can do this procedure. The PCNL can be done even if there is distal obstruction. Okay, I can remove these stones. Okay, that is what is done. So what are the complications of this? Yes, obviously hematuria, pain, these are complications, but the most common complication here, as we are puncturing the skin and subcutaneous tissue, it can lead to bruising. So bruising is the most common complication of PCNL. Now coming into another complication, those are unique to PCNL. There may be pneumothorax, okay, or there may be pleural injury, okay, and there may be splenic injury also in the left side, PCNL. Okay, there may be colonic injury. How? Colonic injury because between this abdominal wall and the kidney, okay, there may be the colon. If there is a colon entrapped in between them, and if I putting this nephroscope and guide wire and nephroscope, then it will perforate through the bowel. So that can cause colonic injury. Okay, so in the way if the pleura comes, or can cause pneumothorax, or the spleen comes, that can cause splenic injury. Same. Okay, that is PCNL. Now another advanced procedure is what is known as RIRS, that is your retrograde intrarenal surgery. Now here we are not going percutaneously, neither we are providing any shock waves. So here what we are doing is putting a ureteroscope through the urethra, urinary bladder, and then going to the required ureter, and then we are removing the stone by a specialized basket, that is a wire basket, that is known as Dormia basket. This is Dormia basket. Okay, that is there. So if it is ureteric stone, so it can be removed, that is what is known as URS, that is ureteroscopic removal of stones. Or if it is a renal stone, then I have to reach up till the pelvis and I have to remove these stones, that is RIRS. Both are same, basically depending on the location, the name is there, URS or RIRS. Okay, now this is I am not making any hole like PCNL, I am not providing any wave, okay, or I am not creating any scar. So this is very much advanced surgery. Okay, the Dormia basket is used to retrieve the stone out. So this is in short the stones and their management. Okay, sometimes we can also use the lasers to laser, and that laser can be used to shatter the stones. And what laser is used, the question is asked, that is holmium Yug laser. This was a question asked. Okay, right, thank you.